Yeah, thank you, John. And thank you for making my job easier, because I was supposed to introduce the MDG Alliance, but now I don't have to. Except I will say that while it's tapping into the private sector, and we have some extraordinary leaders from the private sector, it's actually multi-sectoral too. So it's not just the private sector, which GBC does extremely well, but it's actually using the private sector as an entry point to bring a multi-sectoral response, working close with the United Nations, non-governmental organizations, and others. So it really is a pulled together opportunity. And it really begins with focusing on where the burden of the Millennium Development Goal challenges are. So focusing on countries. So it's not everything, but really trying to focus on where most of the problem is and the key interventions that can overcome those challenges to achieve the MDGs and pull people together to achieve that using, as John said, the expertise of the private sector. So it's a great privilege to moderate this panel. For the ground rules, we're not doing opening statements. I find those boring, so it was nice to cross those off when we had our first call. Although it will look like we're doing effectively opening statements. Hopefully they haven't prepared them that way. And then we're going to have a moderated discussion, which is really just on themes, and they actually don't know what the questions are. Actually, I don't know what the questions are. It'll depend on how the conversation goes. And that'll be for about 40 to 45 minutes. Then we're going to open it up to the floor for your input and feedback and discussion with the panel. And I'm not checking my BlackBerry. I actually had to pull it out because, as usual, I didn't wear a watch, and it's the only way I'm going to be able to tell time because there isn't a little clock here. So, without further ado, we're going to get started. And I figured a way to do this would be to go in order of the Millennium Development Goals, if I can remember the order they're in. And that's one of the problems with the MDGs, although they're great, is I can't even remember what the order is or what they are. And so we're going to have a little bit of information on what's going on within those specific Millennium Development Goals to get us all up to speed, and then we're going to get into the topics. So we'll start with LEAP and Millennium Development Goal number 4. And what I'd ask each of you to do is talk a little bit briefly about what the MDG is, so everyone remembers what that number means, and what's exciting about what you're doing today, including any new announcements in the last couple of days. Some of the Alliance members have been meeting with their boards, our leadership groups, to come up with some new announcements. So anything that's really fresh and interesting, if you could just convey that. So we'll start with Millennium Development Goal number 4.
Thank you, Mark. So Alan Batkin and I, Alan's in the room today, are working on Millennium Development Goal 4, which is child mortality. And I wanted to just talk about the numbers here. We have roughly 8 million children dying before their 5th birthday, 8 million. And to achieve Millennium Development Goal 4, we need to bring that number down to 4 million by 2015. That means we have less than 4 years to save 4 million children every year. So it's an enormous challenge. We have a very focused strategy at the MDG Health Alliance. We focus on the leading killers of children. So pneumonia, it's number 1, diarrhea, neonatal deaths, and malaria. That's it. Everything else we view as a distraction. We are focused on those 4 diseases. We're also focused on the countries where most of the children die, and that's a short list too. So India, Nigeria, DRC, Pakistan, and Ethiopia. That's it. Everything else we see as a distraction. So we're very, very, very targeted in our efforts. The optimistic news in child health is there are very simple, cheap interventions that are out there that can prevent most of those deaths. So for diarrhea, it's oral rehydration and zinc, really cheap, easy to make products. With pneumonia, it's an antibiotic called amoxicillin, and that's made by many of the pharma companies in the room. With malaria, it's bed nets and hopefully soon a vaccine. And with neonatal deaths, that's the deaths of babies in the first month of life. There's a handful of things you can do, once again, very cheap. Our challenge is to get those products to the children where most of them, where the deaths are concentrated. So in India, which is our number 1 priority country, a few weeks ago we were in India with the Secretary General of the UN, working on a new public-private partnership around diarrhea. The great thing about India is the private sector there is so strong. There are no reasons why partnering with the private sector there can't solve these problems. So we were thrilled with the company representation that we were able to get in India, and we would invite any companies in the room here with an interest in India or with the capacity to contribute to the scaling up of ORS and zinc, oral rehydration and zinc in India, to join forces with us. We see no reason why we can't prevent almost all child diarrhea deaths in India by partnering with the private sector. And the one other initiative that I really need to mention because of GBC Health's strong mining constituency is zinc. Zinc is one of the big untapped resources in child health. It's a great product for kids. It makes them grow faster and it builds immunity, so they have greater protection against these leading killers. So we have a general call for action to mining companies to join us in a mining compact for child health. We want to see zinc products, whether it's fortification, supplements, the tablets that you need to take when you have child diarrhea, to join forces with us to get zinc products out into these emerging markets and to increase people's understanding of the potential for zinc. So that's two exciting things that we're very happy to announce here, and really call the GBC Health members to come talk to us about joining forces.
Thanks, Lee. And we're going to come back to what people in the room can do on the MDGs as we get towards the end of the moderated period. You know, one of the themes that I think we're going to see is inexpensive things can actually save millions of lives if we actually just focus on them and get them done. And one thing that, as we move to MDG number 5, is the relationship between child health and maternal health, and we're going to see that theme too, because all of these Millennium Development Goals that we see as separate actually come together, and we know that kids are 3 to 10 times more likely to live if mom lives, because mom takes them to the doctor and takes them to school and makes sure they get fed. And the neonatal period is particularly relevant for the mom staying alive. Maybe we can, in the general discussion, come back to that, but why don't we talk about MDG number 5 and the moms, and remembering that moms aren't separate. The kids and the moms go together. So why don't we talk a little bit about that, Naveen?
Yeah, absolutely, Mark. Thanks a lot. Again, I'm back. I was this morning, and so I touched a bit on maternal mortality. But just as you were talking, Mark, somebody had mentioned to me, which I thought was really pathetic for all men in this room. But apparently, when the mother dies, the child and the children, the family, the community, the nation, you know, when a mother bleeds to death, so does the nation. But apparently, when the father dies,
no impact.
No impact. Ouch.
No Father's Day.
But anyway, so I have the privilege of working on MDG 5, and MDG 5 has 2 components to it. MDG 5A, which is a reduction in maternal mortality by 75%, as it was dictated in 1970, and the measure is going to be in 2015, and the idea was to decrease it by 75%. And MDG 5B, which is universal access to reproductive health. So I just want to talk about both of them in the context of the MDG Health Alliance, which is very exciting because the concept of the MDG Health Alliance is taking further Ray Chambers' dream of being able to use multiple partners, whatever pressure, wherever necessary, to be able to get the right people at the table and with a focus and to be able to see if we can save lives that way. And in that regard, MDG 5, the maternal health pillar under the MDG Health Alliance, is also focusing on 5 countries. We're focusing on India, Nigeria, DRC, Ethiopia, and Uganda. And in this regard, one of the ways we are going about it, which you'll hear a bit more from my other colleagues who, when we traveled to India, were able to set up a local business council. The thinking is to do in a local microcosm what Ray was able to do on a macrocosm, is can we get the local businesses, the local people, to take ownership, and that this is not somebody else's problem, this is not something that we are flying in and flying out with, but can we galvanize the local business community. And the reason to do that is that these kind of MDG problems that we're facing, whether it be 4, 5, 6, are all multi-sectorial. We need multiple partners to come together. And so somebody like the MDG Health Alliance can come together and be able to set it up. And just to bring it to another way of looking at it is, I think this was Chris Elias who said it to me the first time, is when a mother dies, it is almost like a house catching fire. And most often, most homes don't catch fire. Similarly, most often, most women give birth without any complications. In fact, 85% of all deliveries are normal and don't have complications. But it's those 15%. And when that house catches fire, and most often we don't know which woman will run into the problem, we need a full fire station on standby. And that concept of having a fire station where all systems go to treat that woman is the kind of mindset we have. And so this is not the burden of national governments, it's not the burden of United Nations, NGOs, it's actually all of us collectively. And the concept is, can the MDG Health Alliance be that glue that brings people together? So very exciting.
Thanks. Thanks a lot. You know, Leith talked a little bit about the countries where most of the children are dying, and not surprisingly, that's also where a lot of the moms are dying. And so I know you all have a geographic focus too, maybe a little less than the kids, but do you want to say anything about the geography and where you're mostly concentrated, or you don't have to? I'm just asking.
Yep, I mean, basically we're going to focus on the first 5 countries. If you look, India, Nigeria together is 30% of all the maternal deaths. Uganda has 6,000, and if you add Ethiopia and DRC, we've basically gone to where the problem is. So we feel that if we make a dent there, we really have a chance to move the needle to achieve MDG 5.
Yeah, and that's a really important point, I think, for all of us, because in almost all of these areas, there's a handful of countries that account for 60 to 80% of the problem, whatever it is. And while some may not call it a distraction, because there are kids and moms dying there, it's still, if you want to have an impact rapidly, some of that focus can really help. And we've seen already how kids and moms relate, which is really important. By the way, we'll get to this later too, but one of the things we don't have yet is a lead from the private sector for reproductive health.
Which I will talk about.
Yeah. And that's really important too, because that helps with a lot of the issues related to moms, especially family planning and spacing, allowing kids to choose families to choose the size of the family that works for them, and that allows them to care for them. So we've already seen these MDGs kind of overlap a little bit, and when you get to MDG 6, which is some of the big health issues, HIV, TB, and malaria, you continue to see this intermeshing. John works on prevention of mother-child transmission, Wendy on malaria. So since we ended with moms there, why don't we go to well, actually moms related to both, but specifically to prevention of mother-child transmission. John, can you tell us a little bit about that MDG, the one you're working on? And you had your meeting yesterday, and I understand some very exciting things happened. So tell us a little bit about what you're doing.
Great. Thank you, and thanks to John for inviting us here. It's been, just as a quick aside, it's been an incredibly interesting journey for me getting involved in this. It started about 6 years ago, actually, with my old friend Jeff Walker and Ray Chambers, who came to me and said, we'd like you to get involved in extreme poverty and global health. And then Ray came 6 months ago, as he did to all of us, and asked us to dive into it. And one thing you'll hear from each of us is that, of course, it's human nature. You spend most of your time doing the things that you enjoy the most. And we all have full-time jobs that we're doing, and we find that this is sort of something that constantly pulls us back. It's been a fascinating part of my life, and everywhere I go and the business people I talk to, you can see the light go on. I think this is really a topic around the MDG Health Alliance issues and these various pillars that its time is really here. And so it's exciting to be sort of a small part of that. The PMTCT initiative was really accelerated about a year ago, just a year and a half ago, when Michelle Sidibe and Eric Gooseby got together and created the Global Steering Group, the GSG, because they observed, as two of the real legendary leaders in this space, that this is an area that we can accelerate very rapidly. There's no real, it's very inexpensive. Mothers are driven to receive this treatment if it's available. And so it was really with their vision, this idea of real acceleration. The quick statistics are 390,000 babies are born each year, HIV positive. It really doesn't exist in the developed world. There are countries like Botswana, which it went from 21% down to 3% very quickly with the leadership of Joy Pumafi and others. So it's one of these topics that is clearly doable. And the idea of eliminating it by 2015, I think, is really within grasp. So Eric and Michelle, when we early on said, you know, how can the private sector play a role here, we started brainstorming right away about each of the critical areas of implementation, whether it's awareness, advocacy, demand creation, logistics, drug availability, stockouts, all the things that many of you in this room deal with every day or are very familiar with. And it's how do we bring this private sector voice to this issue, because there's so many experts in each part of this that exist within UNICEF and UNAIDS and PEPFAR and all these organizations, but having sort of a private sector blend into that, really playing much more of a facilitating role to help spot areas that, you know, decisions need to be made more rapidly, or inconsistent drug regimes, or whatever it is. And so we went about building this Business Leadership Council with the CEOs of companies like McKinsey and NBC and Brian Brink, who's here and I know spoke, who's very active in this and a real leader in this. And on the Global Steering Group, Cynthia Carrolls, who runs Anglo, is on our board. Randy Zuckerberg, who's in the process of taking her company, along with Mark, public today, hopefully, in spite of the markets. Randy is leading our social media initiative. We've got CEOs from Africa, Nady Kirsch, and from a whole series of industries, really. JP Morgan's involved, and each of them feel like they can bring something aside from simply a corporate and social responsibility aspect to this. It's solving the innovative financing problems, it's solving logistics problems, IT problems, scorecarding issues, where they can support this not just with their money, but with their human capital, time, energy, ideas, and get people in the operating side of their businesses to really focus on this. So we put together a board. We had a launch in Davos. Along the way, it became clear that funding is under pressure in the developed world everywhere. So we did some things like take a trip to Africa with 6 senators, a number of which were really lobbying against foreign aid and elimination of foreign aid and some things, and that was very productive, and we're spending a lot of time in Washington on things like advocacy to make sure foreign aid funding continues. The first board meeting, official board meeting we had yesterday, and to get everybody's up to speed, and we have many of the board members, or a number of the board members who are the legendary players in this, Johnson & Johnson, with Michael Sneed and Anu, who I think is here, and as I mentioned, Anglo and Chevron. Rhonda, I think, is also here. So it's both the people that have been big supporters and are very knowledgeable, but most of the board are people who are fairly new to this. And so to have both the existing people talk about what they're doing and how they're able to do it within the core parts of their organizations, and get the light bulb to go on in each of these other organizations where the people from NBC can say, you know, we can find ways, we are great storytellers. So whether that's in the village, talking to moms, or whether that's domestically creating advocacy and awareness around issues like that, it's tapping into the heartstrings of each of these organizations. So there's a lot left to be done, but we've got some priorities around which countries we're going to focus on, which we'll talk about a little later.
Yeah. So one thing you talked about briefly, John, was the messaging marketing piece. And one thing you talked about on maternal and child health was, if mothers would access, same with the children, if people would access services. And we even see in Ethiopia where there's a whole network out there, people don't necessarily come in unless they know about it, which makes sense, right? You talked a little bit about ORS Zinc, which is mostly a marketing demand creation issue, not a money issue. So can you talk, that's something the private sector does exquisitely well. I would have to say governments don't do it particularly well, NGOs somewhere in between. But can you tell us a little bit, maybe, and each of you, or those of you who want to weigh in, can talk a little bit about the importance of that demand creation and the importance of creating messaging that gets people in, and how the private sector can contribute in a way that others can't really get at these issues. Do you want to talk about that a little bit? Does anyone else want to talk about how demand creation, certainly very relevant for ORS Zinc, how we get people to actually access services, even if it's not necessarily true that if you create it, build it, they will come. Sometimes you actually have to get them there. So you talked a little bit about, but are any of your groups concentrating on that messaging, marketing, demand creation piece?
Yeah, it's a critical part of, I think, all of these issues. In PMTCT, it's really testing, initiation, and retention. 3 very straightforward and simple steps, which each piece, of course, can be, when you get down into the details of it, can be very complex. But about half of the HIV-infected mothers fall out because they don't get to a clinic. And so this idea of demand creation, if we can't crack that, we've got a fundamental issue. And by the way, retention is also an important issue, which has some awareness aspects. But I think it's going to be, like many things in life, just a multi-pronged approach. A lot of these things have already been experimented with. We were talking last week with the Minister of Health from Nigeria, Mohamed Pate, about some of the cash transfer ideas that they've been experimenting with, which seem, we've looked at some other countries which are testing that, which seem to be incredibly productive. But there's also education, and Jeff's going to talk about mobile education, e-education, there's telecom, and then just broad-based training and awareness activities. My experience is these things become viral, and there are definitely social and stigma issues that are involved that will be very complex, but these do become viral, and it's community by community. And all of this really needs to be authored on the ground by these countries and by these states anyways. Any one of these healthcare systems issues, that's where the magic is going to occur. So it's really the funders and the people who help implement, and people like the Business Leadership Council and the various pillars that will help really create some of these ideas or refine some of these ideas and help get them implemented.
We were in India 2 weeks ago, a bunch of us, and Bollywood really came out. And so the messaging on polio was very effective when it was delivered through SOAPs in India and others, and particularly the two-shot requirement. And so they're here to take the next set of messages out. And so you're sitting leveraging them is going to be huge. But it's that local media base and that local wireless base that we need to access.
That's actually an excellent point, because you both raise is that you're involving local companies, not just global companies. And if what you message in one country is going to be very different than another, and involving those local folks is going to help determine what's going to be most successful.
So we had like McCann local to India and DDB local to India. So they're going, we can really rally our teams as well. So global actors in those local spaces is important too.
Using the right form of communication. With malaria, we know that these $10 bed nets work if people sleep under them. And in Senegal, we were lucky enough to work with Youssou N'Dour. He became a big champion. And there was concerts, and it was the media company that he had and used, and was terrific. We were also doing something called Night Watch, though, which is using SMS technology to remind people every night, getting their 9 o'clock beep that says, are you sleeping under a net? Is your child sleeping under a net? So using that technology has also worked. So being able to, I think, watching the innovation and then highlighting where it's working and sharing those practices is also working.
And thanks for raising Night Watch as a board member of Malaria No More, which is doing that program. That's great. Naveen, did you want to say something?
You finish.
Okay. No, I was just going to see if you wanted to jump in, because I was going to ask Jeff about electronic devices for education.
Yeah, just one thing on the private sector and why we do demand creation so well. And the approach we need to take here is that not to approach this, and I keep saying mothers because I'm focused on MDG 5, but you could translate it to anybody within our MDGs, is that to approach them as consumers with respect, and not recipients of charity, and hence presume that they don't know what quality is. They don't know, they have no judgment on the experience they get in these facilities. So demand creation is not just awareness, but also making sure that the experience that these mothers have is a desirable experience. It doesn't matter how much demand you say when she goes there, and many often this is what happens, that there's one lady there taking care of 80 pregnant women who's frazzled, and the words she uses, so it's not a pleasant experience. Yeah. But to really treat these as consumers who actually understand value for money, and even though they're not paying here, but they do understand, so it's important also to how you approach this.
Yeah, you're absolutely great point, because the data tell us that quality of services actually will draw people back, and while they're not spending any money, it costs them a day out of their lives, and that is a cost to them. Jeff, since Night Watch was mentioned, that actually uses cell phones to tell people, in addition to the radio, to let them know to sleep under a bed net. I know you've worked a little bit, and some groups have committed to working on e-awareness, electronic awareness campaigns. Do you want to talk a little bit about that before we return to MDG, the pieces of MDG 6, and then healthcare work?
Sure. This could be one of the tipping point acts, in my view. Inputs as to how to get to the outcomes. Whether it's to identify community health workers, train community health workers, get the logistics behind them, change regulatory issues. These are all important variables. One of the key variables we think there's a lot of leverage is e-learning strategies. And the MDG Health Alliance, along with Bar Foundation, ourselves, Austin Hertz, who is here today, And others funded a study with Dahlberg, and we actually just produced it and just published it today, so you can get a copy outside. But a couple of interesting things says that they think they can lower the cost of training community health workers from $65 on average per community health worker down to $15. So dramatic cost savings through working in open systems, through sharing training practices, multiple countries, looking at health ministers, working with other health ministers, looking at NGOs, helping other NGOs. Uganda, for example, was cited as, they listed all the companies and all the NGOs and the health ministers working on different e-learning systems. If they actually got together and produced maybe 2 or 3 instead of 15, they actually could save a lot of funds. And people want to help. They want to work together. It's just using this, I think that's what the Health Alliance is supposed to do. We don't have the answers, but we might be able to help convene and others. And it's funny, when we were in India, we talked about, we were sitting with the Secretary General and also the Minister of Finance and talking about, nobody trusts finance world. Nobody trusts government. Nobody trusts the corporate world. But you know what happens? When they all get together, they start trusting them.
Imagine that.
It's interesting.
Maybe Congress should hear that message too. Let's go back to MDG 6 on health and malaria, which relates to children and mothers very much, and something that a number of us have been working on for a long time, and Wendy, you've been very engaged for a long time. Tell us a little bit about where we are with that and what you're trying to do to get us to the goal for 2015.
Yeah, because technically the Millennium Development Goal, I think it's 6C, which is to halt and reverse the malaria incidence by 2015. But we were lucky enough that in 2008, the Secretary General actually issued another goal, a bolder goal, to get to 0 deaths from malaria by 2015. While doing that, he did name his first special envoy for malaria, my boss, Ray Chambers, who we've talked about. And so Ray took on this charge, and I think being a man of business, one of the first lessons we learned is the importance of setting these quantifiable goals. So 2015 seemed a little daunting in 2008 and 0 deaths, but looking at 2010, immediately we said, what can we do? Let's provide universal coverage of these key interventions. And so 2010 really drove a lot of the work. That was to provide long-lasting insecticide-treated bed nets, rapid diagnostic tests, ACT treatments. The good news is, at the same time, resources were being mobilized from key partners like the US government, the UK, and thanks to GBC member contributions to the Global Fund, and the World Bank. So we did see over $2 billion mobilized, and the result was over 400 million bed nets were deployed, hundreds of millions of ACTs, and rapid diagnostic tests. And good news is it seems to have worked. In the World WHO 2011 report shows that over the last decade, we've seen a 1/3 reduction in malaria deaths. So that's huge. And the exciting thing about that, too, is 70% of that 1/3 actually occurred in the last 3 years of the decade, just as we were scaling up all these interventions. So, no surprise probably, but when you fund things, people use the nets, have access to the treatment, malaria deaths decline. So that's exciting for 2010, but we're still, unfortunately, living in a world where 1 child is dying every minute from malaria. I think the trajectory has continued, 650,000 deaths probably in 2010, or about 500,000 deaths right now, probably in 2012, but we've got to get to 0. And we know that the political and financial commitments have to be sustained if we're going to get there, especially with a disease like malaria. We've seen what happens when we don't keep the bed nets coming, when we don't have access to treatment. We see spikes right away. So our big push right now is still to mobilize resources, public resources and private resources. The good news is probably about 75% of the funding is available to replace the nets and to keep stockouts from happening. But we've got probably a $3.2 billion gap to get to our 2015 goal. So we're looking, the Global Fund, we're hoping is going to be able to do maybe 2/3, again, thanks to people like Chevron and GBC members who are showing their support of the Global Fund. That'll be essential. We have an event in September where we're hoping people will make commitments to the Every Woman, Every Child campaign and to the Global Fund, and even decommitments. Global Fund members are people who had received Global Fund money saying we no longer need the money. But we also need to keep looking to your point about innovation. We need the money, but we need to figure out where are the technologies that are going to get us to 2015. Because we wouldn't have gotten to 2010 if it hadn't been for the new bed nets and the new treatments. So how do we keep looking for those technologies? The vaccine, as Leith alluded to, is our ultimate hope for ending malaria. But until then, we've got to find the technologies that will lower the cost of the current interventions and make other ones more effective and available. And then finally, one of the other big lessons, of course, and most important, and we can all probably talk about this at some point, is the importance of in-country ownership and accountability. And we've been lucky enough to have this group, the African Leaders Malaria Alliance, that we work closely with, 42 heads of state who have committed to making malaria a priority, meet on a regular basis, and kind of share their plans and hold each other accountable.
Thanks a lot, Wendy. You mentioned the Global Fund, and the Global Fund is really important for child health related to malaria. It's incredibly important for prevention of mother-child transmission, which relates to maternal health. And some of you may have noticed my red shoes. They are not a fashion-forward statement. These are actually from Red. And one of the things companies can do is work through Red or through direct contributions to the Global Fund to help close some of these gaps. Because while we've had great progress in all of these areas, we still have huge gaps. And Chevron, as you mentioned, has been a leader. It'd be great to have a couple more companies come in at the level that Chevron's come in at, but also to help on the core competency area. And one of those is supply chain. You've all talked about the need for commodities and what you're doing. It doesn't matter what it is. The commodities are really important. And if we can get them there more efficiently and effectively, then we can actually reduce costs, which will allow us to care for more people. And this, again, is where the US government doesn't do particularly well. No government does particularly well on supply chains, except for the supply chain management system for PEPFAR, which I'm very proud of, which actually involves the private sector. But Mukhtar Kent talked a little bit about what Coca-Cola has done in Tanzania around actually supporting the Global Fund on supply chain. Leith, you've been thinking about the supply chain a little bit, and that's going to cut across everything. Anything you want to talk about or anything exciting happening in the supply chain and how the private sector can contribute?
This is another area, I think, like demand generation, where the private sector can add huge amount of value. So we have this problem across many of these pillars. We have these great products, easy to make, cheap. We know they're effective. And we have all of these children and families and mothers. Typically, the kids that die, and I guess the mums that die, are very poor. They're usually illiterate. They live outside of the cities in these countries, so they're very, very hard to reach. We just have failed as a world to get these products to these families. So supply chain and distribution becomes critical. So what we're looking at the MDG Health Alliance is in our target countries, who are the private sector distributors that have cracked this nut? It's typically the large consumer goods, food and beverage companies who are leading the world in getting products to the furthest reaches. It makes total sense to work and partner with them. But I want to answer this question with a comment I was reading about Jeff Bezos and Amazon.com, who I think are one of the leading companies in the consumer experience. He said he never hosts a meeting without an empty chair, whether it's a board meeting or any kind of internal meeting. And the empty chair is the consumer. And everybody around that table notices that empty chair and is asked to think about who sits in that empty chair and what do they need from us. If we could have every global health meeting with an empty chair and be thinking about who is in that chair, when it comes to health, so often we know who is in that chair. It's a woman. Typically she's aged between 20 and 40. She's poor, she's illiterate, but she has a burning desire to raise healthy children, as all mothers everywhere in the world do. And we have failed to really understand the consumer experience from her perspective. So I would like to see any supply chain or logistics discussion starting from her perspective, from the empty chair. What does she need to get a product to her? And we know that this mum or this woman doesn't really want to travel a long way. She can't. She has multiple children. She's working all day. The nearest health facility is miles away. We have to get products as close to her as possible so it's easy for her to use them. Bring them straight into the home or to a community health worker. Jeff will talk about that. It has to be so simple and easy for her to access health services. And if we have to incentivize her and reward her, why don't we do that? Why isn't she getting rewards for vaccinating her children or rewards for using the right products? Once again, this area of incentivizing consumers is a private sector space. So we need to bring all of our leading private sector thinkers into the global health space to help us solve these problems, and that's really what we are all about.
So getting the supplies to those where people will fill the chairs is really important, but someone that has to be there to deliver it, whether it's for maternal and child health, for prevention of mother-child transmission, malaria, and that's a cross-cutting thing, just like supply chain. Jeff, this is your pillar and what you're working on. So why don't you talk, if you could talk a little bit about the healthcare worker piece and the importance of that, because as Naveen pointed out, if you have the product there and no one to deliver or not deliver in a quality way, that chair may stay empty.
Well, that's why I won't be successful unless the other pillars are successful, and I hope I make them and our team more successful because of our association. And when you look at community health worker, it's seen as the health system advocate, right? The sustainable part of our interventions. And then we started out actually with, let's have 1 million new community health workers. And then we kind of like said, does that make any sense? Just having new ones, there's all sorts of other issues. And so you look at it, you know, with the old JP Morgan, and we sit there going, let's look at a return on investment. What is it made up of? What are those variables that go into improved lives, saved lives, lower health costs, and increases in GDP? If you can actually show which variables you can move that produce higher number of lives saved, increased levels of GDP, you'll get a lot of money. Malaria, like I think it was a 10-to-1 investment. Dollar for net produces amazing return in GDP. Same kind of analysis on the community health worker side. So let's figure out how to find them. Let's figure out how to train them. Let's figure out how to retain them and sustain them. Let's figure out how to supply them. Let's figure out how to change the regulations when they're maybe trained to do something they're just not allowed to do yet. Let's figure out how to measure and evaluate them, and let's put out awareness. So once you break it down into those variables, you can all of a sudden go out and start saying, who are the best people to work on each one of those? And teams start coming together. So the e-learning space we talked to you about, and that's the purpose of this report. And that takes us partway down the road. When you're sitting there looking at logistics and supplies, we've already had a number of software companies, logistics companies saying, we want to participate. Let's set up goals and objectives around each one of those. There's sustainable strategies. There's for-profit double bottom line strategies that a number of people are funding. GSK is funding some. Merck's looking at some of those. So are we. Some are Acumen Fund. Let's start funding some of those that develop local pharmacies, local places for community health workers actually to pay for themselves. Half the community health workers are not paid at all. So how do we build awareness and thank them for the service, but also how do we set it up so that they can stay in job, so that we'll stay in place where they're supposed to be. And then the regulatory side, that's what the business councils really can be helpful to do. So we have local business councils. In India, it was illegal to prescribe zinc, to issue zinc. Community health workers and ASHAs could not do it. They kind of still did informally. We went to the government, went to the ministers, and they all kind of said, that is kind of stupid. We're going to change the rule, and 2 months later, we think it's going to be completely legalized. We should be doing that on all the other drugs that you all in the pharmaceutical world have. We should figure out how to get through all the distribution companies. We in my old job used to own some distribution companies, drug distribution companies. So let's figure out how to team the Western world's drug distribution companies with the local distribution companies to get it there. Hindustan Lever's putting their hand up. You know, we've got Bristol Myers putting their hand up. This is, you know, a place that we can aggregate a lot of that action to increase the output of those levers that generate the endpoint outcomes. And the community health workers could be in the center of all that.
Thanks, Joe. That's really helpful. You know, the Minister of Health in Ethiopia, who's put out over 30,000 healthcare workers and health posts all over, he calls what you described the software. He put the hardware in place, but now the software is not there. And while governments and non-governmental organizations can help with that, the private sector is probably uniquely situated to help with some of their software components that you described. You know, the other area of the healthcare sector, when we've been talking a lot about how the private sector contributes and can contribute to accelerating the achievement of the MDGs. One thing we don't talk about a lot is, especially in Africa, India, Asia, where many of these problems exist, the private healthcare sector is actually growing at a very rapid rate. And how do we tap into that with some of these things to make sure that they're of high quality and that they're actually serving and meeting these needs? And Naveen, can you want to talk about that a little bit?
Sure. Before I get that, one thing I wanted to bring up, I think it's now that you've heard from all of us, is we have realized that ourselves, we don't work, we've been using the word pillar, but we understand very clearly that there are synergies here, and one of the ways that we want to approach it, and the way we're envisioning ourselves approaching it, is to look at a concept of, say, the year of the birth, and we're looking at the 24 hours around the delivery as the midpoint, and then if you go 6 months before that and start with antenatal visits and make sure that the woman comes in, but the birth itself is facilitated in a facility with skilled birth attendants. And then what can we do 6 months after, which would also include neonatal, because the most deaths occur around the 24 hours of the first few months of delivery, how can we make sure that the child is protected? Then also exclusive breastfeeding, which is another known implementation that saves lives and is healthy. So can we wrap ourselves around this 1 year, which would also include postpartum contraceptive options? So they were trying to see, can we bring, and within that, can we also test the mother for HIV, and if positive, then go on to a PMTCT protocol. So we're trying to bring it all together and see if we really have a platform where the MDG Health Alliance, even though we call pillars, that we are all working together closely. And in that regard, if you look, and to come back to exactly what you've asked, Mark, is how do the private sector play in? And really the three levers, to use Jeff's analogy here, the levers are really, it comes down to quality, access, and affordability. And we really do believe that the public sector, along with the private sector, with national governments, with the United Nations agencies, with the World Bank, United Nations Foundation, UN Commodities, there's so many players in this, but if we really come together, we really believe that if we focus on truly quality, access, and affordability, that is what the private sector can bring. And I think we're on to something where we feel, at least we're excited.
Thank you.
One second. So at Millennium Promise, we had Ericsson being a huge contributor to our villages, and they provided cell phone towers and cellular phones. And what they discovered was they thought it was a philanthropic act, and at the end they discovered it was a smart business strategy. Yeah. And they started making some decent money in the rural strategy, so it opened up a whole market opportunity for them. Right. I think that's what we're going to continue to start finding is as people experiment using, whether it's not just foundation, but with philanthropic orientation, those will turn into prototypes that say, yeah, there is actually a business model here that I can make money off of.
And there may be a business model in direct provision of health services too, as we're seeing emerge in a number of countries. You know, Naveen, you mentioned the first year, and that's a really important place to focus. I mean, we also want to make sure that the fifth birthday is really important too, getting out to 5. And I just want to mention for everyone that the U.S. government with USAID, the government of India, and Ethiopia, 2 big countries for a lot of the issues we're talking about, in June are holding a meeting to really focus on a 5th birthday campaign to try to get every kid to their 5th birthday and what it takes. And a lot of what we've talked about is going to be essential, and all these components that we've talked about are part of that campaign and effort to get everyone to their 5th birthday. So if anyone want to post your 5th birthday picture, you can go to the USAID website and put it up there just to remind everyone that we should all have a 5th birthday. The last question to all of you, really quickly, you know, a minute each, on what can the people in this room do to contribute or be part of this effort? Because it's really important, and there's a real intersection here of the people in the room, and then we're going to open it up. I can take moderator's prerogative on 2 things. 1, Global Fund. 2, what we haven't talked about is one of MDG number 6, which is tuberculosis. And the reason for that is because we don't yet have a private sector lead for HIV-TB. And one of the goals of the MDG Alliance is to end co-infection with HIV-TB and death from that. And there's no reason we can't do that. And they really are one disease in sub-Saharan Africa, as many of you know. So if anyone is interested in that and want to put up their hand, you can contact anyone here or Ray Chambers. So let's go around quickly, just down in order, what the private sector can do to support the work you're doing or engage with you. John?
Sure. You know, I think what Naveen was describing, what the Alliance serves as, each one of these problems is really a healthcare systems problem. You really can't deal with PMTCT just by itself because you need to deal with community health workers, you need to deal with things that overlap tremendously. But what we have seen is this is a great point of entry to start to solve these problems. Any one of these is a great point of entry. And certain things resonate with some organizations and other things will resonate with others. And so as you, and you're all here because you're interested in this topic, think about your organizations. It's really to figure out what might resonate inside your organization within the sort of core operational people, within the executives, whether they're domestic or international, that you think you can help light that light bulb. Because any one of us would love to be in there talking to your organization. We each are pretty good at selling what we do and helping light that light. And being open-minded and finding ways to get your businesses active and involved. And so I think it's just helping turn that fire up because this is an issue whose time is here.
Thanks. Lee?
To the companies in the room, if you have interest in India, Nigeria, DRC, Pakistan or Ethiopia, and you want great opportunities to invest in children, I mean big impact opportunities in terms of lives saved, we would love to speak with you about the diarrhea partnerships. If you're a pharma company that manufactures amoxicillin and you have interest in that product in those target countries, we would love to speak with you. And I think the biggest opportunity here at this conference is for the mining companies. Traditionally, the mining sector has not thought of itself as child-focused, but with zinc and the micronutrient area in general, mining companies have a huge contribution to make to global child health. Right after our panel, Canadian mining company Teck will be talking about their multi-million-dollar investment in zinc for child health. They're one of the only companies in the world doing this. They're getting a lot of attention for it. Please listen to what they're doing, and if you're a mining company, please copy them.
Wendy?
I would say two areas. One is many of the companies here have great networks in the countries where we're working. So as Leith was saying, that's so important, in helping to access leadership in those countries would be tremendous. And second is on communications, both in the countries where we're working and then here. I think one of the challenges is that we're not always good at telling our own story. A lot of terrific things are happening, and I don't think we're getting enough of that out. And at the end of the day, the US government especially is still going to be one of the biggest funders and should remain a leader in this work, but we've got to remind people why we should make that investment. And so helping us communicate that back to the US public, I think, is something we need to work on, and this group would be great at.
And Congress and the administration, not just the public.
Sorry, yes, exactly.
Jeff?
Local country managers should be on each of our local business councils. Wireless companies ought to be helping us transmit our knowledge, gather our data, and train everyone that's involved. Health knowledge and support from the drug companies and health services companies, critical in our logistics systems. Software companies should be working with us, but get your employees involved, make it so it's a real part and partnership with everyone in your industry, but also what we bring to bear is Johns Hopkins is dying to participate with all of us. Harvard has already taken on the commitment in malaria to bring it down to zero in their entire university. And so we've got great academic knowledge, we've got great NGO knowledge, we've got great corporate knowledge coming together. This is an opportunity to join with somebody to get it done.
Naveen?
First, I just want to use the opportunity to talk about family planning, and we are starting another pillar. Kathy Calvin, a United Nations Foundation, is going to be leading up the MDG 5B, which is reproductive health family planning pillar. And actually, I never forget when somebody opened my eyes and said, the only thing that cuts across all MDGs, not just health MDGs, whether it's poverty, education, family planning is the only one intervention that actually positively affects all MDGs. So we're focused on MDG 5B, family planning, and I'd be remiss if I didn't say that. But having said that, from our own experience at Merck, when we started Merck for Mothers, which is MDG 5, we have no products, no expertise, and the board of directors asked me why, what the hell are we doing here? And basically, very quickly we realized, and this is something that I want to leave with all you people to think about, is this is not, don't think of this as corporate strategy, corporate responsibility or philanthropy. Think of this as strategy. It's like that Sinatra song, if you can make it here, you can make it anywhere. What you will learn in being relevant to resource-poor settings can only sharpen the saw in your own company. So think of this as a strategy too, and it's amazing how many opportunities open up. So approach this as something is helping yourselves while you're helping others.
Thanks a lot. I would actually add that education, especially for girls and women's empowerment, also cuts across, and actually maternal health, the common denominator there is women. Now we're going to open it up to the audience for participation. I'd love to have, we'll take maybe 3 questions in a row and then ask for a response. We have about 10 minutes for questions or comments, please.
The Alliance, as it clearly underpins all of the other initiatives. The question that I have is regarding the focus on the community level healthcare workers and whether or not there are plans or just your thoughts on the role of other levels of healthcare workers as part of the entire healthcare system.
Thanks. Before we go to an answer, which are there other hands up? I really can't see.
Yeah, in the back.
Joe, go ahead.
All the way in the back.
Okay. There's someone over here, so why don't you just go ahead.
Good afternoon. Hi there. My name's Clinton D'Souza. I work for a company called RTT. We're an African-based supply chain company and part of the PEPFAR supply chain solution that seems to be working fairly well. I just wanted to share a quick thought and then maybe ask how we can maybe get involved. So we're not anything like as big as some of the organizations here. We're relatively small in size. But we're involved with a program in Kenya where we are responsible through USAID and CDC to run a lab program, a lab distribution program that goes down to about 5,000 individual healthcare points in all 11 odd provinces in Kenya. And we've managed to, so our responsibility in that is the warehousing of the goods and then the physical distribution, getting the goods down to all these thousands of healthcare centers, some of them very, very informal indeed. And the way we've been able to sort of manage that over the last couple of years is through a collaborative approach with local transportation companies. And it's the management of these local entities, and not one. There isn't one that can go to all these little places. We work with about 5 or 6. So I just wanted to share that as maybe something to think about, and specifically, Lyth, just thinking about your very focused view on the countries. You know, one of the countries we are involved with and growing our involvement is Nigeria. And then I guess just not being a Chevron or an Anglo, a lot smaller in size, how could a company like ours potentially get involved by maybe offering our expertise in some other ways? Thank you.
Thanks. Is there a microphone at the back? Otherwise we can, there we go. Okay.
Thank you. 2 questions. One is, the focus is on big countries. I think it's very important not to also forget the small ones with a great need, the Chad, the Southern Sudan, the Papua New Guineas, the Nepals. I think there's a need for a bit of equity. But coming back to these big countries, Ethiopia, Nigeria, India, Pakistan, but why is the business model working in Ethiopia? It's achieving very fast, very quick, and it's delivering on the MDGs. Why? What are the success factors of that model? And then the last point is, my appeal is there in the corporate sector, those in the producers or others, who can really help in marketing for malaria, the spraying of houses where that poor mother and child and the father can sleep safely. And that's delivered at the house level. How do you market that as compared to the nets? Because that's a very powerful intervention for malaria control, and it's always forgotten. But that's what brings malaria down.
Thanks. I'm not sure it's always forgotten since there's some huge spraying campaigns, but why don't we just ask the panel to respond to any of the questions you want, and I'll go down in order, and then I'm afraid we're going to have to wrap up.
I can quickly address the spraying issue. Actually, a GBC initiative, CAMA, Corporate Alliance for Malaria in Africa, CAMA, just actually issued, they co-sponsored an event on the business case for indoor residual spraying, along with academic institutions, corporations, WHO, and the Rollback Malaria Partnership. And to your point, looking at how do we create more of a market for this, we've still only got, correct me if I'm wrong, Mark, about 10% penetration in terms of IRS for certain reasons, but there are big campaigns out there, and it's great to see GBC through CAMA taking a lead on this. Yeah.
But I think it's less of a household issue because that's a government thing that is a spraying campaign. You don't actually ask a house if they want to do it. The government just does it. It's more a global health issue and around spraying itself. So John, any of those questions resonate with you? You want to respond to any of them?
Sure. I think the question from RTT, about RTT and how they can get involved is a critical one. And you know, out of each of these, there are going to be demonstration projects. And that's where we're finding tremendous leverage from the private sector. And so one example, Norm Payson, who's a doctor, has owned some very, very large businesses, runs Apria Healthcare now, which is an enormous US healthcare-based business, but has practiced medicine in Africa over time, understands the issues. He's helping us work with all the big funders and implementers to figure out which drug regime should be used. And we're going to be talking to the Global Steering Group and others to kind of centralize and figure out why each country in Africa is adopting a different drug regime. Well, the logistics is the exact same thing. It's not that RTT can necessarily impact all of sub-Saharan Africa or India or other markets, but when we go into a country or a region and we're trying to create this demonstration project, the experience that you have is incredibly invaluable, and it's creating a blueprint that can then be rolled out on much greater scale.
Any quick answers to any other questions? We're running out of time, so that'd be really short.
Just the criticism about the focus on the countries, because I think we will hear this. Anytime you pick a selection of countries to work in or issues, you receive criticism. But I would say one of the reasons we are off track globally with many of the MDGs is we have not focused our efforts as a global community on the leading killers of children or mothers, and we have not focused in the countries where the burden is highest for many reasons, many of them political reasons. But I think part of turning that around is focusing our efforts and building big, broad partnerships across the public and private sectors. We need to bring the faith communities in. They have a huge role to play in global health, and all the NGOs. If we can collectively focus our efforts on the leading causes of death in the highest burden countries, that is our very best strategy to make accelerated gains. And that's what the MDG Health Alliance is all about. It's hastening achievement of those goals.
So I'm afraid we have to end because Michael's standing up. So the panelists will be around if you want to do individual questions with them and follow up on some of these. And please join me in thanking the panel for an excellent discussion.